Hello everyone, and welcome to this Open Hand webinar, brought to you in association with the University of Witwatersrand and the South African Society of Hand Therapists. So my name is Nicola, and I'm going to be your host. The topic for today's webinar is simple ideas for a complex problem, tips and tricks for treating complex regional pain syndrome. So there will be a 45-minute presentation, followed by time for questions. And you can post your questions in the chat box throughout the presentation. If you have any questions about this or about anything else, then you can send us an email and we will get back to you. But for now, it's time to start our webinar. So we are very privileged this evening to be joined by Janine Hareau from Uruguay. She is a pioneer in hand therapy with a few decades of experience in the field. She received a physical therapy degree in Montevideo, Uruguay, before going on to obtain a degree in occupational therapy from the University of Wisconsin in the United States. She returned to Uruguay as the first OT in her country and established a private hand therapy clinic, which she still runs today. She later obtained a PhD from Nova Southeastern University in Fort Lauderdale, Florida. She is also one of the founders of the Teleton Pediatric Rehabilitation Center. She is a professor and director of the occupational therapy program at the University in Montevideo. She has published numerous articles, contributed to various textbooks, and conducted hand therapy workshops all over the world. And I, for one, am really looking forward to hearing what she has to teach us tonight. Thank you, Janine.
Thank you. What am I gonna try to convey today? I'm gonna try in very short time to speak with an incredibly difficult topic. Difficult because it has a lot of angles to work on. And this is what we're going to try to talk about in this very short amount of time. And now we'll go back to the presentation. Thank you very much for inviting me. And as I said, this is what I will try in this webinar. You can read faster than what I can talk. So read what it's in the screen. Okay. Complexity, as you may be able to apply. Complex regional pain syndrome is complex. It's not easy. And please, for the younger ones, foster the desire to reach out and ask when you need help and you get stuck. Go and reach. Somebody will always answer your questions. Now, I'm going to talk about understanding a little bit of our body, the kinetic body. The kinetic body is the expression of the beauty of our body. It's the expression of how we do things. Now look at these two videos. Look at the lady on the top. Look how clumsy she is. Now look at the lady on the bottom. She's a young girl. Look, this is a complex regional pain syndrome only of the elbow. So when we look at the upper limb movement analysis, we always have to remember the neurocontrol. And the neurocontrol goes straight through the cerebellum. So we have an unconscious control where we have the posture. Posture is completely destroyed in complex regional pain syndrome. We have the joint stability. Stability, they're very stable because they're very stiff. This is a lady with RA. And we have the feet forward control. Very few people remember what's feet forward. But once you see these little videos, you will know what is feet forward. This is feet forward. Feet forward is a capacity that we have to do something without thinking. You get up early in the morning, you get out of bed, you don't think. If you think, you fall down. You learn feet forward. This is a learned activity. And you lose feet forward when you don't perform the activity. Complex regional pain syndrome patients forget the movement. They have no idea how they should move. On the other side, we have the conscious control, where we have the somatosensory, touch, pain, and temperature. So they have problems with temperature, problems with pain, and problems with touch. You cannot touch the patients. Don't touch them. Don't worry. You will be able to touch them on due time. Don't be so in tune to just to touch the patient, especially the first time you see them. And then you have the voluntary proprioception. Proprioception is something that everything and everybody talks about, and it's so difficult. Kinesthesia. What's kinesthesia? It's what you learned. Learning how to swim, learning how to play the guitar, learning how to do something will foster kinesthesia. It's a learned activity. Then you make it an activity that's automatic. And then what do you have? Joint position sense. Joint position sense that you can perform at the clinic in a very simple way. And the forced reproduction. Forced reproduction, it's what? It's a capacity that we have to make a dough and thin the dough in the same way and not make it thick on one side and thin on the other side. The capacity that we should have in both arms to reproduce the strength. And again, you have a wee board, sophisticated, and a dough, unsophisticated, and a ball, medium sophistication. They all will do exactly the same, force reproduction. So now you have some ideas for treatment already. Do we really know what it is? Actually, we have no idea what it is, complex regional pain syndrome. No idea. We have an idea of what it does, that we are missing that key point, that key idea that allows us to know exactly what happens. We do know, however, that it's an incidence factor in fractures, and 25% of all upper extremity fractures are wrist fractures, and 60% of the women that were treated with cast develop complex regional pain syndrome. Scary, eh? Very scary. 40% foot, 60% arms, 41 ladies to gentlemen, greater incidence in this age range. And what has happened in the latest years, children with complex regional pain syndrome, and 85% occurring in girls. We all know the Valencian consensus. This was done in 2019, where a new criteria was open, where they talked about a complex regional pain syndrome without all the array of problems. So the first thing is, if you have a patient that has a lot of pain, just think of the patient like a complex regional pain syndrome. If the other things happen to happen, fine. If they don't worry. But don't be so in tune as to have absolutely everything: allodynia, vasomotor changes, pseudomotor, edema, trophic changes, etc., etc. Some will have it and some will not have it, and they still have a complex regional pain syndrome. So, vasomotor instability, look at that hand. Persistent edema. What is the differential diagnosis of persistent edema? Mastectomy. Many ladies have a wrist fracture and a mastectomy. Watch it. Edema might not be due to the complex regional pain syndrome, it might be due to the mastectomy. You have to work both things. Pseudomotor changes, palmar fasciitis, very frequent. Dupuytren is not palmar fasciitis. One thing is Dupuytren, the other thing is palmar fasciitis. Finger point fingers, hair growth, thickness, straighted nails, flexed fingers, taut skin, all those things might happen, or one or two of them. And what usually happens is a kinesiophobia. Even without pain, the kinesiophobia is always present. I don't want to move my hand. My hand might be painful. I don't know what to do with my hand. My hand is clumsy. My hand or my arm doesn't do what it should be doing. So what do we have to do? We have to help the patient organize the movement. We have to start therapy ASAP. The sooner, the better. Don't try to move your patients. Don't try to move them. They need to relax. They need to build confidence. They have a lot of difficulty in memory work. So if you're sending them with exercise at home, make sure they write that down or video what you do or what you want them to do, because otherwise they will not remember how to perform the exercise. Play games. Use multiple variety of approaches. Use warm water. Some will tolerate warm water, some will not. Well, lukewarm or even soft cold water. Let them enjoy therapy. It shouldn't be tortured therapy. They should enjoy coming to you. There are common characteristics to CPRA patients of all ages and types of injuries. They have the physical characteristics, and then you have them all there. And the emotional ones. And these emotional ones, if you have treated complex regional pain syndrome, you know that many of them are coupled together in one person. They have a lot of fear to return driving. They have difficulty returning to work. Sometimes they even have difficulties in family relationship. They have an incredible emotional liability. They look like CVA patients. They start crying and they start laughing and then they cry again. And I don't want to move the hand and it's horrible. And this hand is horrible. And then I had a good time yesterday and now I have a bad time today. It's all an emotional difficulty. It's completely torn the emotional area in the complex regional pain syndrome. And the other thing it's very common is that they cling to you. You are great. You are fantastic. So make sure that when you treat them, don't let them cling to you. They have to be free from you. You have to be in charge, but they have to be able to do things. And another area is that the hand or the limb is all there is in that person's life. Look at the thickness of the joints. And this is very simple. This is how I put Coban, so patients can put it. That's it. Simple like that. And then they can take it out like a little sleeve. Coban, just Coban on fingers. As much as they can use it during the day. Another tip for your treatment. If you wrap Coban, you wrap it like on a strip. Usually they wrap one turn more than the next one. So they make little indentations. No, just rub it around the finger. Gently rub it around the finger. Okay, how to increase passive movement? Because I have to talk about passive movement and edema and Okay, you can use masking tape. You put the hand in warm water, very gently. Don't push those fingers once they let you do this. It might take a week, 2 or 3 weeks to be able to do this. And you put them in warm water, in a pan. If you don't have a hydrotherapy tank, you put them in a pan. Okay, and sometimes I even let the patients do that. Okay, But there is a tip for this. Warning. When you let go, don't let go very fast. Do it gently on one side, gently on the next side. Okay, now we treat the fear of pain, the kinesiophobia. The kinesiophobia is due to an abnormal brain system morphology. We have the brain that's all twisted. We have motor, sensory, affective pain, and autonomic systems at the level of the central nervous systems that have changed. This is not the spinal cord, this is the central nervous system. Therefore, what do we use? Virtual reality. Now, ladies and gentlemen, don't throw those games that you had, those Xboxes, those Wii, those old things that you have. If you buy a virtual reality system, next day it will be outdated. So go back to those fairs and get some of these old stuff that still work and use it in the clinic. So we have applications. On the right hand, we have lenses. On the bottom, we have a We2, and the gentleman who's resting is a complex regional pain syndrome. And this gentleman is drinking mate. Okay, we give them mate. Mate is a beverage that we drink in our country. And that's a we. Okay, so we have several applications. So look at his hand. Okay, look at the movements he does in prone supination. This lady was not using her hand. Okay. Virtual reality helps people feel more in control of their action. However, virtual reality alone does not work. It has to be combined with purposeful activities. It becomes an effective tool if they can get out of the tool and start realizing that they can move their hand and do other tasks in daily life. Mirror therapy. We've heard about mirror therapy, and one of the questions is how much time you use it. Very well. I don't use it a lot of time, maybe 5 minutes, 10 minutes, to help the patient understand how to open their hands and close their hands. And now look at the lady on the bottom. The lady on the bottom, look at the thumb. The thumb is not working. So my aim is to teach her how to use her thumb again. This lady has a dystonic thumb, something that happens very often in complex regional pain syndrome. They have dystonic hands. Dystonia is a movement on the brain that it's not working the way it should be. It's completely twisted, turned, destroyed. They've lost the kinetic sense of movement. In 2020, Monica Halika, she's from Great Britain, wrote this outstanding article. It's one of the best articles I've read of complex regional pain syndrome in the last 20 years. Why is this such an outstanding? Because she goes away with the idea that you have to move and move and move and move, and comes back to the idea that you have to organize the central nervous system. And she has done a number of studies. And this is what she found: abnormalities of brain responses, dystonia in movements. And what did we find? And what did she find? We found out that complex regional pain syndrome the patients have less white matter. Now, why does it happen? We have no idea, but they do have less white matter. Now, white matter is what forms the cortical spinal bundle. What does the cortical spinal bundle does at the central nervous system is the movement ability. So they don't have enough information in the hand to move the hand correctly. Now, why does it happen? And how come after a while they recover? We have no idea. Not yet. Probably we will, but not yet. So look at the cortical spinal tract, the blue one. The blue one is smaller. You have the normal and the CRPS, small. And the spinothalamic tract, smaller. Again, we have a reduction in both hemispheres. So we have a problem. Houston, we have a problem. All this time we have been engaged in getting that hand to move, and we have not been engaged in getting the brain to move. So involvement of the central nervous system is important. So we have dozens of options. Let's see what we are looking. We have an ultra high function. We have decreased attention to the limb. We have hemispatial neglect, but we don't have brain lesions. Funny, no? So we have distorted body representation, deficit in lateralized spatial cognition, impaired higher cognitive functions, and we have to aim our treatment and address neuropsychological changes to improve clinical outcomes. How do we do that? Okay, because none of us is a neuropsychologist. So we're looking to simple things. Patients have poor awareness of position, so let them work on position. How do we work on position? Look at this lady. Look at her fingers. Look, she can't even hold a ball. Look. She can hold the ball and she cannot open the hand. She has to open her hand. And now look at this lady. The only thing I asked her was to open and close her hand with her arm up, and look what she does. She has no idea what to do with her arm. No idea what to do. I ask her a simple thing and she does whatever she wants to do. Okay? She has lack of precision in posturing, lack of precision in target control. And I show you this simple game, okay? In the tempo of adjustment, mental rotation. Now, how do we do this? Very simple. This is a simple game. Anyone can have it at the clinic. Look how simple this game is. Just put a towel, put one cartlet's the target, and ask the person to throw the cards. And look what happens. One goes in, the next one goes out of the table, the next one goes close. A simple thing as throwing a card is not possible. You miss the target. Okay, so start doing things where they can actually work on target control. Get them to work on target control. Don't worry about the movement. Don't worry how much he flexes her wrist. That will come. Let them understand how to organize that movement. Put together a series of pictures. You don't have to buy expensive cards. Laterality cards, fine. Those are great. They're not enough. Make some pictures of yourself. If you don't know how to do them, ask them. I will gladly send you my pictures. They are not, how they call it? They're not protected by anybody. They're my pictures, my hands of my colleagues. You can have them if you need them. Okay? Limb movement sense. Simple ball, one hand to the next one. And tactile spatial attention, one finger after the other one. And you tell the patient, index, middle, so you cue the patient in what to move. Don't touch him, cue the patient. He has to learn what to do. He has to imitate movement. Up and down. Up and down and getting closer to the thumb. And another thing, everything is great, everything is estupendo, everything is fantastic, everything is wonderful. Even if they do the clumsiest movement in the world, they have to have a positive feedback. Another thing, invite patients to a good cup of coffee, have good music, smell, nice environment, that they need to be relaxed. Invite them to a good cup of coffee or good cup of tea in some countries, a smelly, nice cup of something, or a juice, or a piece of fruit. Be careful that they don't choke, or a piece of fruit, or anything that you have, a little piece of chocolate, something that you share with the patient, and that will help them to relax and to create a nice environment and a nice sense of good feeling and happy feeling. This is now on the upper part, it's the same girl in the bottom part. Only complex regional pelvic syndrome that I've seen, only of the elbow, incredible, with no lesion. There's nothing in the elbow. Now, so what do we put? We put fishes, and she has a good, and then what does the therapist say? Flex the elbow, flex the elbow, flex the elbow, flex the elbow, and finally she does it. And on the bottom part, it's all October, November, December. Okay. Visual motor problems. They have problems crossing midline. Okay. Make them work on this. Very simple. You can find it on a toy store. Write the exercise to be done at home. Now, look how interesting. They have problems crossing midline, put them this. They have also problems counting with mental arithmetic, reading, repeating, writing, coping, identifying numbers, letters, spelling. So you write everything down. You put them exercise, you write the exercises, you show them how to make the exercise, to perform the exercise, you send them in WhatsApp, you give them by writing, whatever you want. You ask them to film the exercises, whatever you want. Don't spend money. You know what it is? This is a rubber band. Oh, wow. A simple rubber band. And they can do multiple exercises with a rubber band, isometric contractions, isokinetic contractions, repetitions, 5 repetitions, 10 repetitions. Send them exercise at home, and then they should tell you what they've done. Now, usually the movement is so primitive that you need to go one step down. And what do I use? I use a balloon. Yes, ladies and gentlemen, a simple balloon. What's the effect of a balloon? A balloon won't hurt you. A balloon takes you back to younger years where you were young and you could do a lot of things. a balloon slowly goes up, slowly goes down. It won't hurt your face. It won't hurt your face. But you see the lady is unable to move her arm. Her kinesthetic sense of movement is very primitive, very primitive. So we play with a balloon, and she can play at home with a balloon. They also have construction apraxia. So we work with 3D puzzles. These are complex puzzles. And this is another game that you think it's easy. It's not easy. It's not easy at all. That's a Shenga. I don't know how it's called in your country. They're wood blocks. Make them just play with somebody else with wood blocks. This is Mr. Potato Head. Now, you give a Mr. Potato Head to an older person and they'll look and they would say, I didn't come here to play. But if they understand what you want exactly from them, they will enjoy it. They will enjoy it very much. They will actually laugh. Okay, and believe me, the lady up there is a surgeon. The lady down there is somebody in the government. Okay, this is a highly educated patients. And I have low educated patients and highly educated patients, and they all go for the same treatment. Control, motor control. Okay, many of you know what it is. These are not easy at all. You can play games. You can play championships with this. This is a lady. Okay, look at her hands at the beginning. Right hand. And this is the other part of the treatment. Okay, we hardly ever touch her. And this is another game, very simple. This is for motor control. Now, this game is very simple. Every time you bang in this little thing, there will be a sound, quite nasty sound, like breaking of a glass. So she has to go and try to make it as fast as you can. Now, the funny thing is that this is a lady with complete regional pain syndrome, totally rehabilitated. I did it, she did it faster than me, and she was much better than me. So for those who are PTs, I do a lot of electrical stim, S-stim, a lot. I do extensor tendons, I do triceps, I do biceps, I do flexors. Okay, I work alternated. I work with that NMES. If I have a lot of pain, for instance, in shoulder, I do TENS. I do TENS on shoulders, TENS on elbows. Careful with doing TENS on hands. Complex regional pain syndromes usually don't tolerate TENS on hands. Usually, they might, but not necessarily. This is an NMES machine. Okay, biphasic, alternated, or synchronic. A lot of hydrotherapy, if I can. Hydrotherapy in some countries, like in my country, you can get hydrotherapy in the clubs. Otherwise, if you have a pool, try to just go and swim, ask the patients to go and swim. If you have the ocean, coach them into swimming. Okay, teach them what to do into swimming. Okay, and you coach them, you tell them what to do, either walk, either swing their arms, either move their hands. This is swimming to reproduce a kinesthetic understanding of movement. They start very slowly and gently. They are able to start swimming better and better and better. Granted, many people don't swim, so you have to show them simple exercise. They can have a floating device, and they can go into a pool where they can just float and move their arms and move their fingers. Right? They have to do some kind of exercise, some kind, so the brain starts working again. So aerobic group exercises. Running is not for everybody, but they can go on a walking spree. You ask them to go shopping, or you ask them to come and go to the clinic, from the clinic to their house, and from the house to a clinic walking. This is extremely important. They have to start doing something aerobic and something that they can actually pace themselves. Now, I teach my patients to go into the gym or to dance. This is Mundo Gushi. This is Mundo Gushi. Mundo Gushi doesn't pay me a penny. Nobody pays me a penny to foster this. It is just a place where you can get into your phone and work with a group of people. Look at the arms. Look at their arms when they move. Now, this gentleman starts from the very, very basic things to the very complex things. The nice thing about this group, if you see, is it's a group where it does all sorts of exercises, and there are different array of people. There are people who are very good, there are people who are excellent, and there are people who are very bad and do exactly the opposite of what he does. And that's nice. That's nice, because most of the patients won't have the possibility to start on a dance group where they do everything okay. It is also very important that they start cooking, that they start going back to work. Now, how do you foster for them to go back to work? Sometimes I do things at the clinic that are similar to their job. I even take them out driving on my car. I have good insurance, and when they say that they cannot drive a car because they're unable to really feel comfortable, I say, okay, now you're ready to drive. I'm going to take you out. And I take them to a place where they can maneuver and see if they can work on maneuvers and see if they can understand what the sense of movement they have to apply so they don't bang into everything. Now, complex regional pain syndrome is a very complex problem, and we have to address it with a smile. Okay, I really, really want to be able to answer questions, and I know many of you have many questions. So if I have to show something else, I will gladly show it again. But please, I'm going to stop sharing the screen, and I'm going to try to answer any of the questions, or if it's something that I did not explain correctly, please feel free to ask.
Thank you, Janine, for a great presentation. It's always such a privilege to learn from you. So we do, in fact, have quite a few questions. The first question is, how do you explain what CRPS is to a patient?
How do I explain CRPS to the patients?
Yes.
Okay. Okay. They say that I have complex regional pain syndrome. Oh, yes, you do have it. Do you understand what it is? No idea. Well, I don't have any idea either. We say, what? No, I don't have any idea either. I can only explain the symptoms. I cannot explain what it is because nobody knows what it is. So I know you have swelling, I know you have pain, but I do know that your brain is completely disorganized. And my therapy is going to try to help you out. I am going to be your coach. I am going to help you out, but the one who's going to really, really do the treatment is yourself. You are the one who's going to really work on reorganizing your brain. Incredible explanation, but it does work. We all have worked with incredible injuries. I know I now have 2 major forearm cuts, 2 major forearm hands, a completely torn hand with no complex regional pain syndrome. And I have a little lady with a little fracture and a complex regional pain syndrome in her whole arm. Therefore, something that we don't understand is going in there.
Thank you. Then our second question is, do you usually confirm the diagnosis of CRPS with specific tests or imaging, or do you just look out for common signs?
Usually they will have, to confirm the diagnosis, you need at least 2 symptoms. Or a lot of pain, or the fear of pain, the brain disorganization, palmar fasciitis, or edema, or anything. If there's 2 of them, I just treat them unless. But again, I have almost 40 years of experience working with this. I have hundreds of complex regional pain syndromes from my hand in the past. If I, by any doubt, I will send them to a general practitioner or anything, because there's one type of complex regional pain syndrome that it's due to a heart problem, an infarction. So you have to be careful. And that's the way if I think it's a vasculitis, for instance, because of the difference in I will ask him to have some other tests. But the problem, or not the problem that we are a very small country. I know many of my patients. I know where the general practitioner is. I know what the hospital is, so I can send them, and I might have next day the answer if I have a doubt. Okay, a blood clot, a tumor, a CVA. Okay, I've had one complex regional pain syndrome that was not a complex regional pain syndrome, it was a CVA. Okay, so it's completely different. So it had to be, yes, I treated and it worked fine, but it was not a complex regional pain. And I had a CVA with a complex regional pain syndrome, both things.
Okay. And then does chronic regional pain syndrome, can it affect just one finger, or does it always affect all the fingers or the whole hand?
1 finger, 2 fingers, the whole hand, the whole arm, the whole body. I've had complex regional pain syndromes with facial problems. I had complex regional pain syndromes with 1 leg, 2 legs, and I had 1 systemic, only one in my whole life, and I hope I won't never have another one again. Okay.
And does CRPS usually happen after some sort of injury, or can it happen spontaneously as well?
Oh no, that's doesn't need to happen only in the injury. That young lady that you saw had only a little bit. Okay, Uruguay, it was 4th on the World Championship, and one of her soccer players came to the school, and she was pushed through the shoulder. Zoom, complex regional pain syndrome on her elbow. They thought it was a brachial plexus injury. Now, no brachial plexus injury can have a C5, C7, C8 injury with complete hand and complete shoulder. I mean, it was a complex regional pain syndrome. So it can happen on the shoulder, but usually on the same side. Eh? You will not have it on the other side. But with 1 finger, you can have a whole hand. With 1 hand, you can have an elbow. That's why it's so complex. Usually it stands to the hand, but many people have the hand with complex regional pain syndrome and they don't have flexor extension or shoulder elevation. Okay, so it's more like a CVA. Actually, when you look at your patients, look at the way they go into the clinic. They have different pace. They walk differently. They protect their arm. They look more like a CVA patient than a traumatic patient. Therefore, you have to treat them more with the array of tricks of a CVA than the array of tricks of trauma, without forgetting that you do have to work on the trauma itself. But the trauma itself is minimum with the consequences of the complex regional pain syndrome. I work on wrist flexion and extension. I work on wrist supination. But if they don't use their hand, it doesn't matter what you work on. First, you have to let them use their hand. And then you work on flexion and extension when the patient starts allowing you to touch him.
Okay, and what is usually the prognosis for these conditions? So what do you tell patients to expect in terms of improvement and how long it will take?
How long does it take? Well, that's a good question with a bad answer. Some patients might take a year. Some patients might take a couple of months. Some patients might take 3 or 4 months. At one point, they have to do the click. If they don't do the click, it's very hard for you to rehabilitate the patient. At one point, and you have no idea, I had this lady who came 1 week, terrible. Second week, terrible. Third week, terrible. Fourth week, terrible. And all of a sudden, she came on Monday. She was fantastic. And I said, what did it change? And she looks at me and said, well, during the weekend, I was with my niece and her kids, and I played all day long. And I said, if Janine tells me to use her hand, I have to use it. Otherwise, I would not be able to play with those kids. And she played. And Monday, her hand was not swollen. And said that was a difference. She was not alone during the weekend.
Okay. And then there's also a question on electrical stimulation. When do you start with that? Do you start with electrical stimulation from the beginning, or do you only do it a bit later?
It depends. If usually if I start with electrical stimulation as early as I can, as early as the patient will tolerate it. And what I do, I do electrical stimulation as the same way I do it with my kids. I put it on and I do not turn it on. And I work on something else. So then the patient says, this is not working. Oh, I forgot to turn it on. Oh, I'm sorry. So I turn it on a little bit. Said, it's still not working. Oh, maybe a little bit. No, why don't you turn it just a little bit higher yourself? Oh, okay. Oh, this is too high. Okay, put it down a little bit. And she starts doing something else. And then I build a tolerance. You have to build a tolerance at the central nervous system. Okay, the hand will tolerate. Careful with esteem and careful with a tendon transfer or tendon suture. Careful, okay? We're talking about fractures that are okay, that are healed, there's no problem using it. Esteem with a tendon transfer, with a blood clot, with a nerve transfer, something like that, you have to use cautious. It's another protocol. Ask. I will teach you how to do it, but ask.
What is your opinion about corticosteroid medication, Janine?
If it works, it works. But usually, for many people, it does not work.
Okay, thank you.
We use a lot of gabapentin, and vitamin C. And for some patients, it does work. And for some patients, it does not work. There are some neurologists that are really good about, putting people on medication. I would say that many of my patients are not in any medication, except on simple pain killers. But the story behind this, or the trick, or the it's to treat those patients as soon as you can. So I have a number of to take doctor's prescription. Yes, I know in many countries they take a lot of doctor's prescriptions, but many times those patients get to therapy late. They go from one doctor to the other one, and finally they go to therapy because they have so much pain that they don't start therapy. And then in some places they go to therapy and the patient comes in and starts moving those hands and go and go and go. They go away. So my patients, as soon as a doctor just even thinks or just even suspects there might be complex regional pain syndrome, they're sent to me really early. And if I cannot move the hand or the forearm because of the surgery, I can move the arm, and I can start organizing the brain, and I can start helping the patient get into maybe walking, or maybe doing something with their legs, or something with the other arm, or just do something, start organizing the brain and start controlling pain. Pain can be controlled, and pain can also be enlarged. Okay? And if you think how pain can be controlled, just think what you do with a young child that you take for the first vaccine. Do you tell the child, look at your vaccine, it's gonna hurt? It'll never come again. But if you just distract the child, yeah, it might cry a little bit, but it will not remember that vaccine is something horrible.
Can the effectiveness of sensory re-education as an intervention for CRPS be measured?
Okay, it all depends on what kind of injury you have. First of all, sensory re-education, you have to qualify what you mean by sensory re-education. Sensory re-education as such does not exist. If your sensory system does not feel, it does not exist. But, for instance, being able to determine this is soft and this is soft and this is hard and this is hard for the brain that's baloney, completely baloney. Now, being able to identify an apple from a banana, the peel of an apple from the peel of an orange, the peel of an orange from the peel of a kiwi, that is sensory re-education. Because what you educate is the idea of the sensation. When we touch something that means something to us, we are able to understand. So you have a cut nerve and you want to re-educate the nerve. You start with what I would call real sensory ideas to the brain. And then you go to maybe a cloth or maybe another tissue. Then you educate. Now you have to be very careful with what sensory education, re-education on complex regional pain syndrome patients, because they might have allodynia. If you have allodynia, that sensation that you're trying to re-educate will probably go to another place and start being painful, and then you go back and let them touch, put them textures. Okay, this is, I don't like this texture. Okay, let's work with this one. Oh, I don't like, but put in soft balls and put in nah. Give them pebbles, give them things to arm, give them a piece of wood, give them fruit, and then you can re-educate. You do sensory re-education. Okay. I call life textures, textures that mean something, different ones, but that they mean something to the brain. Okay, a game with plastic little bricks or a game with wood little bricks. And again, I do, Coban doesn't help a lot with that icky sensation that they have. They have sensation. Coban does help. This lower down the nociceptive receptors at the brain. And lowering down the nociceptive receptors, it's not that for them to touch, it's not so horrible for them to touch. And I have psychiatrists that I have had complex regional pain syndrome patients that are psychiatrists and psychologists. And I still have to go through this explanation. And once they understand, the complex regional pain syndrome goes down.
Thank you, Janine. Also, in the vein of sensation, would a gentle desensitization program sometimes be used for a CRPS patient, or would that be too threatening?
I have never used it. No.
Okay.
No, if I can provide them with another thing. Okay. No. They will go into it themselves, but it's useless. No, it's useless. If you follow a little bit of my tricks, you realize that, you know, if they come back home and say, you know what, I was able to make a fruit salad. Oh, yes. Maybe at the beginning, I didn't want to touch those fruits. They were yucky on my hand. But then I said, my family needs a fruit salad, and I'm going to make a fruit salad. And I was able to do it. Best desensitization program on the world.
Wonderful.
Okay.
And a final short question. Are you aware of research on the use of cognitive behavioral therapy and its effectiveness?
Yes, but very few research. They're just starting. They're doing Monica Halika is starting in England the cognitive behavior research. Yes, I haven't been able to get through in this country. They've done it with children also, but they don't have enough number of complex regional pain syndromes that will send them to the cognitive behavior research to get numbers to do this. But actually, I would say that what we do is a little bit of coaching into this area and helping out. Some of my patients, I am able to get them into a psychologist, and it's a lot easier, but most of them, they will not go. They will not go to a psychologist, a psychiatrist. They will not go. And they are not sent, and that's quite expensive in my country. So a number of them don't have enough money to pay. But yes, they are starting cognitive behavior research, and I hope to get numbers and good papers soon. Get the paper from Monica. You have it on the handout that I said. It's worth reading it. It's really worth reading it and writing it down and putting it down into practice. Okay, it's useless if it's paper. It's great if you understand this is how I practice with my patients.
Okay, so we're running out of time, so that's all we have questions we have time for tonight. So we can just close off quickly. Okay, so thank you all for joining us this evening, and thank you to Janine for your amazing presentation. Our next webinar will be on the 3rd of June, and the topic will be managing the median nerve, regaining motion and sensation after wrist level lacerations. So you can look out for the link to register soon. Then you can follow us on social media, you can subscribe to our YouTube channel and join our mailing list, and then we also hope to see you all in our next webinar. Thank you.
Good evening to everybody. Good day for me and for the ones in South America.